All right, welcome everyone to our June session of the Medicaid Insights Colloquium. We're really excited to have everyone join us today. We're just going to give everyone a few moments to finish filtering in, and then we'll get started. All right. Hello, everyone. Welcome again to the Medicaid Insights Colloquium, also known as Mike. Thanks, everyone, for tuning in with us today. I'm Megan Kolbrahim. I am an associate professor and division director in the Division of Health Policy and Insurance Research in the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. So as usual, I'll start just by going over a few quick notes about our time together today, and then we will jump into our presentation. All right, so to start, this session will run for about an hour in total. We'll have 40 minutes of presentation, followed by about 20 minutes of Q&A. And because there are many of you joining us today, we just ask that you refrain from using the raise hand function. And instead, if you have a question during the presentation, you can submit your question at any time by clicking the Q&A button here on the bottom of your Zoom window. And then after our presentation is over, we'll get to as many questions as we can after the presentation, but don't be afraid to submit those questions as they come. You don't have to wait till the end. And before we start, I'd just like to take a quick moment to recognize my fellow members of the MIC Planning Committee for their continued work in planning these events. So first we have Jane Sue, who is an associate professor and faculty research lead in the Division of General Internal Medicine and Geriatrics at the Oregon Health Sciences University. And we're also joined by Will Sparrow, who is an assistant professor in the Division of Health Policy and Economics in the Department of Population Health at the Weill Cornell Medical College. And now I have the pleasure of introducing our featured speaker, Samantha Artiga. Samantha is a senior vice president and director of racial equity and health policy at the Kaiser Family Foundation. There, she leads research and analysis on how social and economic factors, including discrimination and racism, affect health and access to health for people of color, immigrants, and other underserved populations. Samantha has conducted extensive work related to health and healthcare needs of low-income populations, and she previously served as the associate director of Kaiser Family Foundation's program on Medicaid and the uninsured. She holds a master's degree in health policy from George Washington University. So in today's session, Samantha will shed light on how immigrant families access healthcare in the US by focusing on the role of Medicaid specifically, where we know that for many immigrant families, coverage is often shaped by a complex web of eligibility rules, public programs, and policy decisions. So kind of given that, today Samantha will explore how Medicaid fits into this landscape and discuss current issues, including the impact of increased immigration enforcement activities, eligibility restrictions under HR 1, as well as pending changes to public charge policy. So with that, give Samantha a warm welcome for joining us today, and we will hand the microphone over to you, Samantha. Thank you.
Great, and give me just a second to get these slides up. Okay. Thank you so much for having me here today. I'm really pleased to be able to share this work with you. As mentioned, I'm going to give a broad overview of health and healthcare for immigrant families. And within that, we'll talk about the role of Medicaid and then some of the key policy issues affecting health and well-being for immigrant families going forward. Just want to start with a little bit of an overview of KFF. We are a nonprofit, nonpartisan source of health policy research, polling, and journalism, and we serve a wide array of audiences, including the health policy community, policymakers, the media, and the public. I think one through line through all of the work we do at KFF is a real focus on how policy affects people, and particularly groups of people who have historically been underserved and underrepresented. As part of that effort, we have had a longstanding commitment to amplify the experiences and voices of immigrant families, and that has included a substantial body of policy work over the years, as well as qualitative work, including focus groups and interviews and engagement with the community. And more recently, over the past several years, we've been able to field our survey of immigrants, which is a large nationally representative survey of immigrant adults that we've been conducting several rounds of since 2023. Our most recent round was conducted in conjunction with the New York Times in fall of 2025. And it's really been a vital resource for helping to fill gaps in understanding the immigrant experience, particularly amid the current shifting policy environment. So I want to start with really a broad overview of immigrant families in the US. Our recent data show that there are about 50 million immigrants living in the US today. That includes about even shares of naturalized citizens and non-citizens, who include both lawfully present immigrants as well as undocumented immigrants. I think it's also important to point out that today 1 in 4 children has an immigrant parent, and that most of these children are citizens. And so what we see is that there are a large share of these children living in mixed status immigrant families, where the children are citizens and have eligibility and access to all the programs and services that citizens do, whereas the parents may be non-citizens, including lawfully present or undocumented immigrants, and have more limited access to programs and services themselves, as well as some confusion or concern about accessing services that their children may be eligible for. Starting with really a big picture of what health insurance looks like for non-citizen immigrants in particular, we see that despite them having high employment rates, they have very limited access to employer-based coverage. And this is because they are more likely to work in jobs and industries that may not offer employer-sponsored coverage. And even when that coverage is offered, it may be unaffordable because they're more likely to earn lower incomes. At the same time, non-citizen immigrants face an array of restrictions on eligibility for federally funded coverage. When we look at lawfully present immigrants specifically, some can qualify for Medicaid and the Children's Health Insurance Program, although there are some groups of lawfully present immigrants who remain ineligible. And among those who are eligible, many have to wait 5 years after obtaining a status that qualifies them before they can enroll. Lawfully present immigrants have been able to purchase coverage through the ACA marketplaces and to receive tax credits to offset the cost of that coverage without a waiting period. But as we'll discuss later, even fewer lawfully present immigrants are going to be eligible for these coverage sources going forward. Undocumented immigrants are not eligible to enroll in federally funded coverage, and that includes Medicaid, CHIP, the marketplaces, even enrolling in marketplaces without a subsidy, as well as Medicare. There really is no federal source of coverage that undocumented immigrants are eligible to enroll in. And I just want to flag that deferred action for childhood arrivals status is not considered lawfully present for purposes of health coverage, even though it is a lawfully present status. There have been efforts over prior administrations to make this group eligible for coverage, but most recently under the Trump administration, DACA recipients remain ineligible for coverage and are basically considered undocumented for purposes of health coverage. There is a provision in Medicaid known as emergency Medicaid that allows for Medicaid payments to be made to hospitals and other healthcare providers, providing emergency services to individuals who would otherwise be eligible for Medicaid, but for their immigration status. However, this is really a payment source for providers rather than a source of coverage for individuals. Now, within Medicaid and CHIP, there are some options for states to expand coverage for lawfully present immigrants. In particular, I want to highlight what's known as the IKEA option, which allows states to cover lawfully residing children and or pregnant people without a 5-year waiting period. And as you can see from our most recent Medicaid eligibility and enrollment survey data, many states have taken up this option. In many cases, they've taken it up for both children and pregnant people. There are some states that have only taken it up for children, and there are 2 states that have only taken it up for pregnant people. And we'll be talking about this option again when we are examining what's going to change under HR1 and what will remain available. Beyond the options in Medicaid and CHIP, there are some states that use their own funds to create wholly state-funded programs that help fill coverage gaps for immigrants. So these programs can provide a source of coverage for undocumented immigrants who, again, remain ineligible for federally funded coverage options. They can also help fill some of the gaps in coverage for lawfully present immigrants, for example, those in the 5-year waiting period for Medicaid and CHIP. To date, most of these programs have focused on children and in a few cases pregnant people. There are a small number of states that have also created programs that extend this type of coverage to adults or certain groups of adults. However, as we'll be discussing later, we're starting to see some rollbacks in this coverage. So this is not necessarily a stable or ongoing source of coverage since it's subject to state financing and budget pressures. And when you think about that whole coverage landscape in terms of access to coverage, when you look at what we have in terms of the data on uninsured rates, I think it makes sense. We see that from our KFF survey, that likely undocumented immigrants are most likely to go without insurance, with nearly half reporting that they didn't have coverage in the survey. Lawfully present immigrants also have a relatively high uninsured rate, with over 1 in 5 saying that they're uninsured. In contrast, naturalized citizens have an uninsured rate that is more similar to US born adults, reflecting that they have the same access to coverage options as their US born peers. Our data also show that state policy decisions around coverage and expanding coverage for immigrants does make a difference in uninsured rates. So when we look at our survey data and group states in terms of more expansive coverage policies, so states that have both expanded Medicaid for their low-income population generally, have taken up the option to expand Medicaid and CHIP for lawfully present immigrant children and pregnant people, as well as states that have created fully state-funded programs. We see that immigrants living in those states with more expansive coverage are much less likely to be uninsured than those living in states that have less expansive coverage policies for immigrants. So, I mean, I think the takeaway here is that state policy choices can make a real difference in terms of what we see in coverage rates. I also want to highlight some of the aspects to think about in terms of coverage for children in immigrant families. And here, I think it's important to recognize that parental immigration status has important implications for children's coverage rates. So we'll see that even citizen children are more likely to be uninsured when they have at least one non-citizen parent. They're almost twice as likely to be uninsured as citizen children where both parents are citizens. And when we look at the small number of children who themselves are non-citizens, their uninsured rate is even higher at 26%. And reflecting these differences in coverage and higher uninsured rates among non-citizen immigrants, as well as other barriers to accessing care, including confusion, fears, potential language access challenges, we see that non-citizen immigrants face more barriers to accessing care than their citizen counterparts. Here we see a couple of measures here in terms of not having a usual source of care other than the emergency room, or skipping or postponing care in the past year. So the coverage patterns then translate into patterns that we see in terms of access to care. Next, I want to shift and talk about how recent policy changes are impacting health and healthcare for immigrant families. And there really are just a wide array of different policies that are impacting families. I'm going to focus on some, and I like to bucket them in a few categories here. The first is really what we've seen in terms of the huge ramp up in immigration enforcement activity since President Trump took office. Here, we've seen both an increase in the enforcement activity, including very public enforcement activity in communities, as well as an expansion to focus on all people who are undocumented versus those who are just criminals, which was a more targeted enforcement policy we saw in prior years. I think another important change to note is a policy change to allow immigration enforcement activity to occur at locations that had previously been protected from enforcement, and that includes hospitals, healthcare providers, schools, churches, and other places of worship. So those places that previously had been identified as safe from enforcement are no longer safe spaces for families. The other bucket of activity that I want to highlight is related to access to health coverage and other services. So there are increased eligibility restrictions for lawfully present immigrants that are going to be going into place under the 2025 Reconciliation Law, or HR 1. The administration also made a policy change to expand the list of federal health and social supports that are limited to only certain lawfully present immigrants. This is a category called immigrants with qualified status. So it's basically a subset of lawfully present immigrants. It's the same subset that's currently eligible for Medicaid and CHIP, but the policy has expanded the list of programs and supports that are limited to that subset of lawfully present immigrants. There are ongoing pending changes to public charge policy, which I'll talk about in more detail. And then at the state level, we've begun to see some reductions or rollbacks in state-funded programs that expanded health coverage to immigrants, particularly those programs that were expanding coverage to adults. The last bucket of activities I want to highlight are around data verification and sharing. We've seen some focused, increased oversight on Medicaid eligibility operations, particularly related to verifying immigrant eligibility, even though states have already been required to verify eligible immigration status before enrolling people. There are efforts now requiring states to re-verify that status. The administration has also indicated that it will be sharing, or it is sharing, Medicaid enrollee data with Immigration and Customs Enforcement. And some states are also directly sharing enrollee and/or applicant data with federal immigration enforcement agencies. So there's really a range of different things happening that I think makes people increasingly worried about the safety and privacy of their data, particularly from enforcement authorities. And not surprisingly, what we've seen in this landscape of policy changes is that there's been a real significant uptick in immigrants' worries about being detained or deported. So here you see our survey data from 2023 and 2025, and you can see that the share of immigrant adults who said that they worry that they or a family member could be detained or deported jumped from 26% to 41%. When we look at the 2025 data, it's at 75% for likely undocumented immigrants. But I also want to highlight the relatively large shares who say they're worried among both lawfully present immigrants, with half saying that they have these worries, as well as among naturalized citizens, with nearly 1 in 3 saying that they have these worries. So I think here the point is this is not a fear and a concern that is limited to people who are undocumented. This is really touching across immigrant communities broadly, regardless of status. And these fears also are not limited to adults. They are extending into children in immigrant families. We saw that more than a quarter of immigrant parents said that their children have expressed worries about something bad happening to someone in their family due to immigration status since January 2025. Again, this is highest among parents who are likely undocumented, but still nearly 1 in 4 lawfully present parents and 1 in 5 naturalized citizen parents also say that their children have had these worries since January. And we know from our research, as well as a broad body of other research, that these types of worries have real negative impacts on health. So here you can see that 4 in 10 immigrant adults reported one of at least several negative health impacts due to worries about their immigration status since January. These included things like increased stress, anxiety, or sadness, problems sleeping or eating, as well as worsening health conditions. Again, we see highest rates among those who are likely undocumented, but still naturalized citizens and lawfully present immigrants are also reporting these types of negative health impacts. And again, these negative health impacts also extend to children in families. So here you see the shares of parents who say that at least one of their children has experienced a problem sleeping or eating, changes in school performance or attendance, or behavior problems since January because of these types of worries. And again, we see these impacts being reported across parents of all immigration statuses. I would also point out that there's a large body of research, and the American Academy of Pediatrics has highlighted how immigration-related fears are a toxic stress when experienced among children, and that it can contribute to lifelong negative physical and mental health impacts for children. We also see that there has been an increase in the share of immigrant adults who say they have delayed or gone without health care in the past 12 months. Again, the jump from 22 to 29% between 2023 and 2025 overall. A very large jump for those who are uninsured from 36% to 50%. And you can also see how that breaks out by immigration status as well. And there really are a variety of reasons why immigrants say they are skipping or going without care. The most significant or prevalent would be due to cost or lack of insurance, particularly, not surprisingly, among those who are uninsured. They also cite logistical challenges like not being able to find care at a convenient time or location. And then you see that concern about immigration status is also a factor contributing to people going without care, particularly among those who are uninsured, who also are more likely to be undocumented. Similarly, as we've seen in the previous measures, children are also going without care, and concerns about immigration status play into this as well, particularly among parents who are likely undocumented. Overall, we see that 14% of immigrant parents say that concerns about immigration status contributed to their children going without care, but that share rises to 43% among parents who are likely undocumented. And then thinking about some of those data sharing and data collection issues that I mentioned, we see that this is also a concern for people. About half of immigrant adults say they are very or somewhat concerned about health providers or officials sharing patient information with immigration enforcement. And not surprisingly, these concerns are highest among those who are likely undocumented. And I do want to point out that this survey was fielded before the announcement that CMS would be sharing data with ICE was announced. So these shares are probably even higher now because there hadn't been any formal announcement about data sharing happening at the time that we collected these data. Next, I want to shift a little bit to talk about what's going to be happening in terms of eligibility for coverage. under the 2025 Reconciliation Law, or HR 1. Here, the big takeaway is that about 1.4 million lawfully present immigrants are expected to lose coverage under the law. There are different implementation dates for each of the restrictions that are going into effect. But here you can see that across Medicaid, subsidized ACA marketplace coverage, and Medicare, there is going to be a much more limited group of lawfully present immigrants who will remain eligible for coverage. You can see those groups in blue there. All the groups in orange are losing coverage, and those are all lawfully present categories. You'll see that some of those were previously eligible for Medicaid and CHIP. A broader group were previously eligible for marketplace coverage. And many of these are humanitarian groups like refugees and asylees who will be losing access to coverage. I do want to highlight that under the Medicaid and CHIP column, states will be able to retain coverage provided through the IKEA option that expands coverage for lawfully residing children and pregnant people in states that are offering that coverage. As I mentioned, in addition to those restrictions, HHS expanded the definition of federal public benefits that are limited to lawfully present immigrants who have a qualified status. This definition of qualified immigrants is something that originally went into effect in 1996 under the Personal Responsibility and Work Opportunity Reconciliation Act. At that time, in 1998, there were 31 programs that were identified as federal public benefits that would be limited to this subset of lawfully present immigrants, and those included Medicaid and CHIP. This new policy that was announced in 2025 expanded that list of programs by adding 13 additional programs, including the Community Health Center program and Title X family planning. It also left room to add additional programs in the future. This policy change has been subject to legal challenges, and so implementation of it is paused in a number of areas as that makes its way through the courts. Next, I want to talk a little bit about public charge policy. If you're not familiar with what public charge is, it is a long-standing policy that has allowed federal officials to deny entry to someone into the U.S. or adjustment to LPR status, essentially getting a green card, if they determine that someone is likely at any time to become a public charge. Historically, identifying someone as likely to become a public charge was based on someone likely to be fully dependent on the government for subsistence, and it excluded non-cash programs like health coverage. In 2025, DHS released a proposed rule that would rescind the regulations that were put in place under President Biden that had excluded non-cash programs from these determinations. Rather than replacing with new regulations, the proposal indicates that they plan to provide interpretive and policy tools to officials to guide public charge determinations. The language suggests that immigration officers would be given very broad discretion to make public charge determinations, and that they could consider programs that were previously excluded from these determinations, including Medicaid and CHIP and other non-cash assistance programs. There's also the suggestion that they could, in their determination, that they could include family members' use of these types of programs, which also would be a change compared to prior policy. That final rule the changes to that are pending as of June 2026, although the expectation is that there could be a final determination soon. And what we've seen when there have been proposed changes or changes to public charge in the past is that they would likely lead to decreased participation in public programs, including Medicaid and CHIP, among immigrant families, and that those impacts on participation would be much broader than among those directly impacted by public charge or the rule. simply out of fear and confusion among families. When rules like this change, there's a lot of fear that accessing the program could jeopardize their status, either for enforcement or for adjustment to green card status going in the future. And that these decisions can also impact enrollment among citizen children and families who would not be directly affected by the rule and who would be eligible for coverage. We see that even before these latest changes were announced, that adults were saying they were avoiding assistance programs due to immigration concerns. Here you see the shares that say they stopped participating in a program that helped pay for food, housing, or healthcare since January because they didn't want to draw attention to their or a family member's immigration status, as well as the share that avoided applying for such a program because of those concerns. You'll see that there is variation with higher shares reporting that they avoided or stopped participating in programs if they have a non-citizen in their household, and even higher shares if there was a likely undocumented immigrant in the household. And we've previously done analysis to look at the number of people currently enrolled in Medicaid and CHIP who live in a household with at least one non-citizen who potentially could be at risk for disenrollment due to confusion or fears around changes in this policy. Our last analysis showed that there were about over 13 million people enrolled in Medicaid or CHIP who lived in a household with at least one non-citizen. And if you were to expect disenrollment rates ranging anywhere from 10% to 30%, that could mean 1.3 to 4 million people disenrolling from coverage due to fears and confusion, including significant shares of citizen children. And shifting a little bit from the federal level actions to state level actions, we're really seeing states moving in two directions here. So on one hand, we've seen already several states scaling back state-funded coverage for immigrants due to budget pressures largely. We've also seen some states take action to limit immigrant access to other services, including public health services and education benefits. On the other hand, we've seen a few states considering how to fill gaps in coverage that are going to be created by the 2025 reconciliation law for lawfully present immigrants. We've seen a few states take action focused on coordinating or increasing immigrants' access to services and or enhancing immigrants' access to the workforce. On issues related to immigration and enforcement and data sharing, we also see states moving in two directions. So we see some states are taking action to really enhance and cooperate with federal immigration enforcement activity, including through cooperation agreements or data sharing with the federal government. On the other hand, there are some states taking action to really limit the reach of federal enforcement, for example, trying to recreate that sensitive locations protections for immigrant families, as well as limiting collection or sharing of data with federal authorities. So shifting to think a little bit about what does this all mean when we think about the already complex landscape that immigrants face in terms of accessing health coverage and care, and the wide array of policies that are currently impacting them. Looking ahead, I think we can expect that uninsured rates for immigrants and children in immigrant families are likely going to increase. At the same time, we know that they're facing increased and growing healthcare needs due to the levels of stress and fear they're feeling related to the enhanced enforcement activity. We know that families may be less likely to access needed healthcare due to the combination of both the anticipated coverage losses as well as increased fear, which will likely contribute to worse health problems over the long term. These heightened fears may contribute to both worse physical and mental health, including long-term health impacts for children. Shifting to think a little bit about service providers, they may face decreases in federal funding, as well as increased complexity and challenges complying with the new policies that are being implemented. And states will also be facing decreases in federal financing that are going to require them to make tough choices about making cutbacks in programs or increasing state spending. And at an even broader perspective, policies affecting immigrants may have long-term impacts on the U.S. workforce, particularly in healthcare. When we look at the key role that immigrants play in the workforce, making up nearly 19% of the total workforce and close to 30% of physicians and surgeons, and also a large share of direct long-term care workers. Just highlighting a few of the issues to watch going forward. A lot of the policies I mentioned are subject to ongoing legal challenges, so the outcomes of pending court rulings will be important to watch. There are a few I highlighted here, including birthright citizenship, Medicaid data sharing, the overall status of DACA, temporary protected status designations, that policy to expand the list of federal benefits that are limited to certain lawfully present immigrants, the implementation of lawfully present immigrant eligibility restrictions under H.R. 1, which will be going into place in coming years, the pending public charge regulatory changes, and continued state actions. And lastly, just a few research priorities and challenges, which I'm happy to hear more of your ideas about and to discuss. But I think one key thing will be identifying changes in coverage for immigrants and citizen children and immigrant families. And I think that's going to be very challenging because there's not a good data source to do that in any sort of real time or even with a time delay. There really is just not great data to understand coverage and healthcare for immigrants, particularly by immigration status. Similarly, understanding the impacts of coverage changes on access to care, on health outcomes, on what happens to uncompensated care, use of emergency Medicaid, effects of ongoing stress and fear, including the long-term impacts for children. There are some issues related to health and healthcare in detention centers that have already been brought to light, but there are ongoing concerns about the healthcare being provided in those facilities. Thinking about provider impacts, including how this current environment affects their ability to effectively serve patients, the array of increased administrative challenges they may face trying to protect patients, as well as potential reductions in funding, broader community impacts in terms of how what's happening to immigrant families impacts schools, local economies, and the workforce. And across all of these, as I mentioned, there's a huge challenge of having very limited data. And then there's the added complexity of families having real concerns about sharing any information and how that might impact the limited survey data that we do have available going forward. And with that, I'm going to close, and then I'll look forward to us having our discussion.
Well, thank you so much, Samantha. That was an incredible presentation and some really important data that you're all collecting, despite the fact that it's really raising a lot of concerns, which I think will only get worse over the coming years. We're starting to get some questions coming in through the chat. Please feel free to directly put in any questions you might have for Samantha in our Q&A box, which should be right at the bottom of your Zoom screen. I'll kick us off with a few, but please keep adding those as you think of them. And I'll start with a question, just kind of thinking something maybe that you didn't touch on, and I'm curious to kind of hear more of your thoughts. So you talked a little bit about kind of how states can start to think about mitigating some of these insurance and healthcare access related issues that immigrant populations are facing. And I guess a two-part question, kind of one, I'm wondering if you could say a little bit more about how you see the role of safety net providers like community health centers in this space and kind of things that they could be doing or things that you're seeing on the ground that might help to better enable access to care and engagement in care through trusted care for these populations. And then kind of stepping out a little bit, I'm curious if you can say a little bit more at the state level, if there are any particular states that you've seen that are kind of approaching this in a more exemplary way. So, if of the states that are trying to fill in some of these gaps that you mentioned, are there particular states that have strategies that seem to be closing some of the gaps that we're otherwise seeing?
So I'll start with a little bit focused on how providers can be serving patients during this time and what's going to be happening to them in the future. I think what we've seen is some providers really step up to the plate here to try and make patients feel safe accessing healthcare, and that there you see a variety of things. So there are some specific rules that provide greater protections against enforcement activity when you designate an area as a private space versus a public space. So you need a specific warrant to enter into a private designated space in a healthcare facility. And so there has been some action in facilities to better designate public space versus private space. There's been training among staff about what to do if enforcement officials show up on property, having a set protocol for what to do. I know there have been efforts to provide more telehealth services, to provide more mobile services. So going to families instead of relying on families to come to the space when they may feel very unsafe leaving their homes. Also, some consideration to what is collected in medical charts, given some of the issues around data sharing and just making sure that you're only collecting necessary information, being very cognizant of how you're asking about anything immigration related. I will say that providers, particularly safety net providers, are in a really tough spot though, right? Because all of that requires more time, requires more resources, more complexity, takes away from patient care time to deal with these issues. And at the same time, outside of what's happening in terms of changes to immigrant families specifically, there's a broad array of changes in HR1 that are reducing federal financing overall. So providers are facing these increased strains and demands to serve patients well. At the same time, they're facing decreased federal funding, and so I think it's going to be a really tough situation going forward. And I don't have the answer for that. In terms of state policies, we actually just published a brief that looked at state actions around some of the areas I mentioned, both on access to health coverage and other services, as well as enforcement and data sharing, looking at actions in both directions. So that's on our website, and I'll go ahead and put it in the chat when we have a second. I don't know the states off the top of my head, but we identified states that took action in the 2025 and 2026 legislative sessions. So that highlights a few states where they are either taking more of those protective and expansion options, or where they're rolling back and heightening enforcement activity.
Thank you. I'm just looking at the questions in our chat now. So I'll start with one that asks if you can talk a little bit more about how HR1 impacts state-funded programs, extending Medicaid-like coverage to undocumented immigrants.
Yeah, so when HR1 was being debated, there was a provision that kept coming in and out that would have penalized the match rate for states if they offered these types of state-funded coverage programs. That provision did not ultimately make it into the final version of the law. So the programs are not directly impacted by any provisions in HR1. However, because HR1 makes fewer lawfully present immigrants eligible for federal coverage, there's going to be increased demand or need for state funded coverage, or people will go uninsured. And at the same time, again, thinking about the bigger picture of the overall financial strains facing states going forward due to federal cutbacks in financing, it's going to become increasingly difficult for them to finance these programs. And I think, California, I think, is a really clear case study example of a state that made significant efforts to really expand coverage to all immigrants in the state, and it has faced increasing challenges being able to maintain that coverage, largely due to budgetary pressures, and is now one of the states that is rolling back some of that coverage. So, one of the ongoing challenges when we look at state funded coverage programs is that they are contingent on state financing, which is not always consistent or reliable, and can be, subject to changing priorities. So that's what I think is one of the big challenges around those programs. But again, we are seeing a couple states trying to think about if there are ways they can use state funded coverage to help fill gaps, particularly for those who are going to be losing coverage under HR1.
Yeah. And then we have another question. I think this is kind of a clarifying question, maybe either asking about the Kaiser Family Foundation survey data that you collect or other data sources, but wondering if in your data or maybe in other data sources, is there a good way to identify immigrant ethnicity, particularly they, for example, they're where are they otherwise from?
Yeah, I think in our 2023 reporting, we had more cuts by ethnicity as well as by region or country of origin. I think our 2025 data has less availability on that. All of this is limited by sample size, so it's challenging to make a lot of cuts. In terms of federal data sources, the limitation with those, like if you think about ACS as a federal data source, that will give you citizen, non-citizen, and length of time in the country. It will also give you country of origin, race, ethnicity, but it does not give you immigration status. So you can only know if someone is a non-citizen or a citizen. You will not be able to know whether they're lawfully present or undocumented from any of the federal data sets. There are some complex methods that have been established to impute immigration status onto those federal data sets, which we and others have used, but it's an imperfect science. And I will say, I think one of the bigger issues going forward is going to be the reliability of survey data, particularly for immigrants, given the growing concerns people may have around providing information to official sources.
Absolutely. We have another question in the chat from an MPH student who is a documented immigrant, and she's particularly thinking about a capstone project, which is great, that will include an advocacy component for immigrant communities in Philadelphia. And she's wondering if you have advice to give students who want to create projects that are not just academically strong, but also are meaningful and useful to the communities that they care about and may actually result in some change for those groups.
So this is a great question, and I love this question because this is something we really focused on as part of our survey work when we originally created the survey. And what I will highly encourage you to do is to engage in a participatory research approach. So that would mean really engaging with the community throughout your research project. So identifying organizations or key leaders in the community that you think will have important insights, talking to them about what they think the needs are, what information, what research they think would be helpful, and then really including them as research partners along the way. And that I think is the best way to make sure that you're producing something that the community wants, that they will find useful, and that will ultimately make a difference, I think, in the way that you're seeking.
That's great. And I'll ask, I guess, a related question as so you kind of nicely posed at the end some potential areas for research going forward, particularly kind of given a lot of changes that are happening right now. And I'm curious as you think about kind of these potential areas of research, are there certain questions where you think research could potentially lead to more positive policy change that would benefit immigrant populations, or is there kind of a way we might frame and think about some of that research such that it actually could be valuable in this moment when things are otherwise very challenging?
That's a tough question. I will say, I do want to say, I think, particularly during this time, that it's important to critically think about any research that you may be publishing or putting out, um, and um, and how it may be used. I think um, one aspect that, we have found helpful is documenting how coverage makes a difference in people's lives. And so there is a large body of evidence that shows that when you expand coverage for immigrants, it does make a difference. It improves children's outcomes, it improves pregnant people's outcomes, it improves adults' outcomes. So even though it costs money, it has real benefits, right, in terms of health. The other approach is a less satisfying and longer term approach where I think documenting the harm that is accumulating from policy changes can be helpful in terms of then being used as leverage for change in the future. And we saw this particularly around public charge. I talked about some of the latest pending changes to public charge. This is kind of just the latest in a long term series of changes that have been made to public charge dating back to the first Trump administration, where a series of restrictive changes were made to public charge policy that made families very fearful to access coverage, and documenting the harm that accumulated from those changes was useful evidence for then supporting policy change going forward under the Biden administration that undid a lot of those changes. Now we're back to an area where those changes are being undone again. But so I think you can think about it two ways in terms of identifying policies or approaches that we know help families and how they help families, and not only thinking about the impacts for families themselves, but how those impacts extend more broadly into the health of our communities, into the economies of our communities, into the workforce of our communities. So I think thinking broadly about positive impacts is one avenue, and the flip side of that is documenting harm, thinking about how that can be used to leverage for positive change going forward.
Great, thank you. That's helpful. We have another question. We'll come back to kind of the emergency Medicaid. So we know that states have fair discretion in kind of what their emergency Medicaid programs cover, including things like dialysis and cancer care, lots of delivery related costs. I'm wondering if you could share any thoughts about whether you think that might be under the ability for states to kind of decide what gets covered under those programs, if any of that may be kind of under threat or change kind of under this current
We
administration.
have not seen any specific proposals yet, kind of digging into the nuts and bolts of how emergency Medicaid operates and in terms of the state discretion around um, how they how they get payments to people and what gets paid for. I do want to highlight that HR1 does also have a provision that is going to reduce the expansion match rate for the expansion group for emergency Medicaid. So there will be some reductions there. But the other, I think, piece to think about is um, how use of emergency Medicaid is going to change going forward. So there again, emergency Medicaid pays for services for people who would otherwise be eligible for Medicaid except for immigration status. And that group of people is going to increase under HR1 because fewer people are going to be eligible for Medicaid under HR1. So potentially there's a bigger group of people that will be eligible for emergency Medicaid services. I think there's also questions around what happens to uncompensated care more broadly as more people become uninsured. So I think that's going to be a really important area to watch. Unfortunately, I think it is an area where, again, we just do not have really solid, valid data to really understand what's happening. It may be something where in some states you can get a better look and better understanding in others, but I think at a national level, it's really challenging.
Absolutely. Then I think one final question, kind of zooming out a little bit as we think about kind of the healthcare delivery system and how it kind of best meets the needs of immigrant populations, particularly those who might not have insurance or who may be undocumented. Can you just say a little bit about how those kinds of populations navigate care, where they get care, and are there particular kinds of care that often are particularly challenging for those groups?
Yeah, so I would say community health centers have always been a really important source of care for immigrant families. They often offer linguistically and culturally appropriate services that meet the needs of families. They often have people from the community working in the community health centers, and they're a trusted, safe space for families. I think one of the biggest issues, both in terms of provision of healthcare, as well as even outreach and enrollment into health coverage and other assistance programs, is really identifying and relying on trusted resources in the community. And that's going to vary from to community. So that's something that's going to be very individualized within your community in terms of identifying who are the trusted sources of information and care. But I will say that overall, in polling, we continue to see that healthcare providers really remain a trusted resource. And that also we've seen that community health centers are a primary site of care for many immigrants. Going back to your first question about like what can providers do, I do think that, particularly given some of the concerns around data sharing, the extent to which providers can really try and mitigate fears among families and say, you know, any information you share with me is going to be safe. And again, minimizing the information they're asking for and collecting is going to be very important going forward. But also, I think, you know, thinking about how to reach services more directly into the community, the use of community health workers, promotoras. So not only always thinking about making services and assistance available on site, but how can you help spread access and services out into the community?
Absolutely. So I know we're coming up on time. I think we'll squeeze one last question. We'll try to get this one in short. I know we have a number of other questions coming in. And this one is about navigating Medicaid during pregnancy. And the question is, will reductions in eligibility for lawfully present immigrants impact access to Medicaid for pregnant women? Or are these still groups, or are these groups still able to access medical care during pregnancy?
There's another option in Medicaid that I didn't. So, first of all, states can maintain that IKEA option, which covers lawfully present immigrants, children, and pregnant people. So, states that maintain that option, that coverage will not be impacted by HR 1. States can choose to eliminate that option. So, you know, separate from HR 1, there's the state choice of whether they maintain that coverage option or not. There's an additional option available in Medicaid called from conception to end of pregnancy coverage that states can elect, where they're essentially extending coverage to the fetus, and then that provides coverage during pregnancy, regardless of immigration status. And we have a count of the number of states that have taken up that option as well. And I don't believe that is impacted by HR 1. But in terms of states where there are not specific pregnancy coverage options available, the immigration status categories are going to be limited to those that are eligible under HR 1.
Thank you. Well, I know we're about at time, so I think we're going to stop there with questions. But thank you so much, Samantha, for joining us today and for just all the really, really important work that you and your team are doing on this subject. Um, I'll just note that everybody who joined us today will be receiving a 2-question survey by email. So be sure to look out for that email to help us continue to make our program better. And then finally, we'll be sending out more information about our next speaker come fall. So look out for that and be sure to RSVP on our website, MedicaidInsightsColloquium.com. So thanks so much, everyone, and have a great day.
Thank you.